Hello everyone, my name is Lisa Saw. I'm an intern in the internal medicine program at the University of New Mexico Health Sciences Center. I worked on this poster with Dr. Angela Denham. Today we're going to talk about statin-associated autoimmune myopathy in an older athlete. For some background, 0.002 to 0.003% of patients treated with statins will have statin-associated autoimmune myopathy. The onset typically occurs within 6 months of starting therapy. Symptoms are typically proximal symmetric muscle weakness and tenderness. The diagnosis can be made through different modalities. Creatinine kinase is usually elevated more than 10 times the upper limit. Electromyography shows small amplitude motor unit potentials with increased spontaneous activity characteristic of an active myopathic process. Muscle edema is evident on MRI. And muscle cell necrosis and regeneration are prominent histological features in muscle biopsy specimens from patients with statin-associated autoimmune myopathy. Anti-HMG-CoA reductase antibodies will also be present. The treatment typically includes discontinuing the statin and starting glucocorticoids. With moderate weakness, you can initiate immunosuppressive agents. After 8 to 12 weeks, if there's no improvement, you can add IVIG. Unfortunately, even after treatment, autoimmune symptoms may persist. Reinitiating statins is unsuccessful. Our patient had an interesting presentation of statin-associated autoimmune myopathy. He's a 70-year-old male runner with a past medical history significant for hypertension, alcohol use disorder, generalized anxiety disorder, and coronary artery disease. When he initially presented to our clinic, he complained of increased fatigue for about 3 months. Instead of being able to run 2 to 3 miles 4 times a week, he had just started walking again a few times per week. He had unchanged upper extremity strength. He worked as a barber and had no difficulties at work, either with his arms or with staying on his feet for extended periods of time. It's important to note that he was previously on 40 milligrams of pravastatin since April of 2013 with intermittent adherence. He had been transitioned to 80 milligrams of atorvastatin in March of 2018. Part of the initial workup included obtaining a BMP, liver function test, and a hemoglobin A1C, which you can see below. His AST and ALT were significantly elevated, with an AST of 503 and ALT of 324 units per liter. Further evaluation elicited a creatinine kinase of 14,246, an elevated TSH of 7.16, and a slight increase in his AST and ALT. His ESR and CRP were not elevated. We instructed the patient to stop taking his statin, and we referred him to rheumatology. 2 weeks later, when rheumatology assessed him, he reported worsening symptoms, including progressive weakness and the inability to rise from the seated position without using his arms. The exam revealed hip flexor weakness. Further workup included an extended myositis panel, which was negative except for the presence of anti-HMG-CoA reductase antibodies. He was started on 40 milligrams of prednisone with symptomatic improvement and a decline in his creatinine kinase. 3 months later, his prednisone was weaned down to 20 milligrams daily, and his creatinine kinase continued to decline. Overall, this case is interesting because the patient's presenting symptom was fatigue instead of the classical presentation of proximal muscle weakness and tenderness. Since he could still stand, rise from seated, and work with his arms elevated as a barber for several months, his sharp decrease in running ability was likely the first sign of muscle weakness. Symptoms began years after starting a statin, which is atypical. This is most likely due to his intermittent statin usage that only recently became regular. As his symptoms were mild and resolving with prednisone alone, no immunosuppressive agents were required. The take-home point is that particularly in older athletes, whose usual performance levels may be greater than expected for age, fatigue with exercise or an otherwise unexplained decrease in exercise tolerance may be an early sign of myopathy. Always consider that statin might be the cause of your patient's symptoms. I hope this was informative and you learned a little more about statin-associated autoimmune myopathy in an older athlete. Thank you for your time.